Okay, so it's my pleasure to be able to chair this afternoon session. I'm Kylie. I'm part of the board for the Stroke Recovery Association and also work at RPA as a nurse. So the first thing we're going to do this afternoon is we're going to have a panel session. So we've got, it may not look like it, but at the far corner over there is actually Mark Longworth, who was unfortunately sick today. So Michelle is stepping into his position. He used to be the Stroke Network Manager for the ACI. Next to Mark is Natalie Wilson. She is the current Stroke Network Manager for ACI. Then on this side, we've got Bill O'Brien, who's a neurologist who works in Gosford and TeleStroke. And then on the empty chair next to him is Professor Ken Butcher, who's just taking a phone call and will be out to join us very shortly. This is the lives of working with clinicians. So we are going to be talking about stroke then and now, celebrating the development of New South Wales stroke services. So the first question is going to be to Michelle/Mark, and she's going to talk us through the history and how stroke services were initially set up in New South Wales.
Good afternoon, everybody. Mark Longworth was basically the ACI network manager, Nat's position, from about 2003 to 2016. And it's when there was quite a lot of changes that occurred in New South Wales health, particularly for stroke services during that time. So we've asked Mark to just talk about what he sees as being the key things that brought about that change and what the key points were that improved stroke care for survivors of stroke over that time. So if you don't mind, I'm going to attempt to read what Mark has written for me. So basically, what Mark found particularly of importance was the willingness of clinicians to work outside their normal way of working to actually start looking at how stroke care was provided in New South Wales hospitals and actually challenge themselves to do things differently. The best part of that, which is really important to us, is it wasn't part of their medical service. They weren't actually employed to do this sort of work. It was often done outside in their own spare time, as a lot of the work that you'll hear today is done. And they were really, and it included the first time that clinicians, such as nurses, doctors, allied health, all got together and looked at the whole stroke pathway and how the role each of them played and how they could make that pathway work better for stroke survivors. Oh, goody, somebody's ringing me. Right, sorry, Mark. He's probably already correcting me. That's probably what's happening. So then the next thing that he found really important was the funding application from the clinicians and the health services, because you don't just get money in New South Wales Health. It all has to come from somewhere and it has to go through the right channels to get it. So at that point, ACI held the money and were distributing it to the local health districts. And the local health districts were then able to give it to the neurologist and the allied health in order to put together the stroke units. And Mark said that the quality of the work that came in from those units and those hospitals was exceptional and allowed him to really argue for the case. And then he also said that he found it really important that the administrators at the local health districts also really supported the introduction of stroke units. The other thing that he said was that there was a statewide education program that was taken on what I always called a road trip. And we went to various places around the state. It went to Ballina, Dubbo, Albury. Where else did it go? Anybody else here at the time? No. Yep. Wagga, various places. And what Mark and the team did was they took really strong stroke clinicians from the Sydney metropolitan area out into the regions to give services within the region free education on how to treat stroke, so that even at that stage, Mark and the ACI were really looking at how to get that stroke treatment, excellent stroke treatment, not just in the city, but also out to the country areas. And it was also based on the clinical guidelines that the National Stroke Foundation had put together, which still forms the base of clinical care within New South Wales. And that was a really important thing, that they were actually training staff within the rural areas how to implement the clinical guidelines when they were working with stroke patients. The other thing he wanted me to mention was that the New South Wales clinical audit was also a really important program whereby we were able to gather statistics from all stroke patients that were treated at New South Wales Health institutions and use those audits and those figures in order to argue for more money and more services. And he wanted to speak about this fact that the stroke network broke through the barrier between the metropolitan, the rural and remote and in the regional areas. So we wanted to get clinicians from both the rural and regional in with the city and metropolitan services. And that was done basically through the training, but also getting clinicians on the ACI network from the rural areas as well. But the big shift, and I'm going to take liberty with this, was the introduction of the rural stroke services and the rural stroke coordinators, which took a lot of the services and the expertise that was learned and gained in the city stroke units out to the rural areas, so that services such as Ken's service at TeleStroke had that initial beginning with those stroke nurses and coordinators that operated in rural hospitals. I'll stop there, Kylie. Thank you.
And I need to go back a step and very sincerely apologise. I have forgotten Brenda Booth, although she is not at all forgettable. Another member of our panel from Hobart is Brenda Booth, as you would all know in this room, but sorry, Brenda.
Can you hear me okay from down in Tasmania?
We can, thank you.
Good.
So we've heard about how stroke has got the history of stroke networks. So now, Natalie, would you be able to tell us where we're moving in forward? What's our priorities?
So I thought I'd briefly mention first, God, I just forgot Michelle. Oh, can you tell I'm nervous? Michelle, I got through with my. But firstly, briefly mention, Michelle had just mentioned TeleStroke. I thought, Ken, you might want to talk a bit about TeleStroke, of where we're up to. Later. Oh, why? Oh, okay. Sorry, I'm not allowed to say that. She keeps us on track. So we had just rolled out TeleStroke, and now we've been focusing on what we want to do going forward. The Ministry and the Stroke Network have set out 6 priority areas for stroke, and I can quickly go through them, and Bill might have, and Ken as well, might have things to add. But the first one was data. We heard Teresa Anderson talking earlier before about the 10 EMRs that we've got across the state, and that it's very difficult for us to monitor performance and do quality improvement at a state. Now that we've got the stroke care coordinators together, the Metro CNCs and NPs, how can we now improve if we've got 10 different EMRs and all these different source systems? So a group of clinicians have got together, they've built out a minimum data set for us to start collecting data and tracking it over time to see how we're performing against the Stroke Foundation guidelines. So we've now got over 40 sites contributing data to that. We can start to benchmark and we can start to improve. So that's data. Bill or Ken, anything to add for data? 6, that's one initiative. The second initiative is ICH management. So we've had a big focus on ischemic stroke lately, but not as much on ICH management. So the network has come together to put a guideline together with people with lived experience. So Stephanie Ho and Mabel have been helping out to pull together a guideline. But we don't just want to write a guideline, we want to be able to implement it properly. So we're pulling all the clinicians from rural New South Wales and the Metropolitan Stroke CNCs and our neurologists together and consumers to work out how we can actually implement this guideline throughout the state, so there's equity of care across the state and that we're treating blood pressure or ICH all together the same ways for the best outcomes for the patients. The third one is pre-hospital care, which we're still looking into, but we're looking at the Cardiac Network have just rolled out cardiac monitors throughout all the ambulances in New South Wales. So we're looking at how we can leverage off that to inform the neurologist or the stroke team earlier about the stroke. So before you even get to the hospital, we can start to know about you and start to get things ready like the CT scanner and things like if we need to move you on to another hospital like the Comprehensive Centre for ECR, that can all activate earlier. The fourth one is retrieving patients from those primary centres or the New South Wales TeleStroke to these comprehensive centres if it's required, either for ICH management or for the clot retrieval. So we're working with aeromedical retrievals and the paramedics to help retrieve patients faster. And it all sits around these, probably should have mentioned this slightly earlier, but these 30, 60, 90 targets, which have been set by the sort of nation, and the Ministry of Health endorse them. But it's basically the time metrics that we want to meet, which we are meeting some of them, but not all of them. So these help, these initiatives that we're working towards helps reduce those. So that's LVO bypass. The fifth one is reducing we're focused very much on rural New South Wales, so having a look at the metropolitan centres, leveraging off that data that we were talking about earlier to help reduce that door to needle time, so access to thrombolysis. And I know I've forgotten one, about 6. And then finally, before Kylie cuts me off, there's a medication that we're being Alteplase for thrombolysis, or it's transitioning to tenecteplase. Most of the world are using tenecteplase, so we're just working as a state to implement that medication. And the main reason, same safety and everything, it's just a much easier drug to give. It means we can give it fast and then either move you to the stroke unit or start activating retrievals and the paramedics.
Thank you, Natalie.
Thank you.
So that's looking at where we've come from and where we're heading. So I guess now looking at the barriers, what do you guys all think are the obstacles facing stroke at the moment across the state? Anyone can jump in.
I can say one. I think we're a very vast state, so it's still very difficult for us to get every patient that has had a stroke into a stroke unit, and I think that is a barrier, our distance. So we are working with all the stroke units and those, especially in sort of rural New South Wales. If you're within a 90-minute drive time of a TeleStroke centre, ambulance will take you there. But if you're not, we're working out ways and pathways to move patients from that sort of peripheral hospital or smaller regional hospital into the TeleStroke site. So I see that as one barrier.
I think getting what are, there's pockets of excellence across the state in hyperacute, inpatient, outpatient rehab. And I think there isn't that consistency across all of the sites in all of those pieces, and getting that right. I think getting that right is important. I think we can learn from, we've got great things happening in some bits in Gosford, but there's other spaces that I can see in other sites that they're getting real excellence happening in, say, community rehab, etc. So getting what works well in all of these sites, figuring what that is, and then spreading it across so that it's the standard irrespective of where you are.
Yeah, I think I'm going to just continue on that theme because never had an original idea in my life, but just carry that on. Yeah, I think you could describe stroke care in New South Wales as ranging from truly the best in the world to, in some cases, I mean, not developing world, but it's lacking. A lot of that variability that Bill describes is, I think we have to own it as medical community. It's physician problem. It's a physician problem. A lot of our colleagues think that they're doing really well, but they don't know because they're not looking. And that's why I'm amazed that Nat managed to get all 42 stroke centers in New South Wales to agree to collect data in a unified fashion and contribute to the RISE database. That is no small feat because there are a lot of people marching to the beat of their own drum and think they're doing great, but I can tell you they're not. And you'd be surprised, it's actually more metro than rural and regional New South Wales. There are some things that are not physician related. As has already been said, it's amazing in 2025 that we have an entire LHD without a stroke unit, 4 primary stroke centers that provide pretty good, acute stroke care, which is great. That's the first hour, but that gets the ship out of port. There's a lot to be done to get to the destination, as you all know, that comes after that. And coordinator support, and again, it's difficult for some of the smaller regional LHDs to support that, they feel they're not, they can't justify the FTE, but that person is so important to the stroke journey, I think, as all of you know.
Brenda?
Yeah, I was about to say, Kylie, you mentioned barriers. The first barrier is people recognizing that they're actually having a stroke and acting on it, because we can't get to medical care. Pardon me, I'm full of cold. Get to medical care if they don't recognise, or their family or people around them don't recognise the signs of a stroke and act on calling an ambulance. So, the first barrier, is actually, responding to that stroke is time is brain.
Thank you. So now looking at over the last 25 years in stroke, what do we think are our major accomplishments? And I guess we have different ideas about what that looks like compared to what the stroke survivors might. But can someone talk about what the living guidelines are and how that changed? Ken, you've got a microphone.
Okay. Well, I think if you took 2 things, one would be stroke units, which don't get a lot of, they don't get the credit that they're due. We emphasize lysis and clot retrieval and how amazing these therapies are, which they are, but stroke units save more lives than both of those therapies combined. They actually do save lives, not just disability. And the recognition that that's important. When I first came to Australia as a fellow in 2001, stroke units, I mean, there were a lot of places that said they had a stroke unit, which was a sign, but it wasn't really a stroke unit. The fact that we have standards supported by living guidelines and some form of accreditation for stroke units, I think is number one. And number 2 is lysis. Again, when I came here in 2001, I had already been routinely lysing patients in Canada as a trainee for years, and was surprised at the reticence in the Australian medical community. There are little pockets of it, but it's almost forgotten now. But that's a huge change, right, in the last decade, is that it's accepted. It's recognized to be important. I think a lot of that has to do with one of our strengths in Australia and in New South Wales, is that we do a full multimodal imaging protocol pretty much routinely everywhere. So we've been able to convince the skeptics by showing them, these color images that you see sometimes at these talks, or sort of saying, like, this is how much brain is at risk here, and this is why you're seeing what you're seeing, and this is what we can save. Those would be my biggies.
Bill?
Continuing on, ECR has been a huge, both in terms of its intervention, but also as a way of aggregating the services. I think that it demanded us to really think about teams and sites and putting all of the sort of resourcing that was going to be needed to get this running 24/7 across a state. And that's been, both for the acute patient that gets reperfusion, awesome, but also just that structure and team being built around it has really helped at a broader level. I think, our secondary prevention has changed hugely over the last, 15, 20 years. And, our ability now to prevent second strokes is huge. And I think that's a big thing. A bit like stroke units, it's part of the, in terms of the sexy is reperfusion. lysis, ECR, but, you know, bang for buck, what we're seeing with stroke units, access and the work that gets done there. And then with our secondary prevention is, you know, it's much larger in terms of its global, its big impact. I think, you know, we're moving towards, and these are all steps, but we're moving towards that RISE database and being able to benchmark, and even having the maturity to think that it's important. I think that, you know, we've talked about it as a network for years, but to actually get everybody to commit to it, that's taken a long time to get people to get to that point, that's table stakes. You need to be able to benchmark what good looks like. Yeah.
Nat, are you able to talk about the ambulance as well in yours?
Oh, I was going to add on from what Bill had said and what Mark had mentioned about sort of the groups of the stroke care coordinators from the Rural Stroke Network, as well as the Metro CNCs. I think all of this has been achieved kind of through their leadership as well. So back from 2003 until now, you'll probably find some of them have been around since then. And the reason why we've got such established stroke units and providing good care are because of the stroke care coordinators and the CNCs that are running these stroke units and services. And then the ambulances.
In terms of the fast bypass and things that was.
Oh yeah, so it has come a long way. I'm not sure what year it kind of 2013. Okay, I was heading to America then. But back in 2013, the bypass came in. So that meant that anybody, this only started out, if you had a stroke and your last known well was within 4.5 hours, you would be sent to the nearest stroke unit that provided thrombolysis. And that was within a 90-minute drive time, because you have to factor in how far the paramedics are driving. You don't want them driving too far if it's their end of their shift and they've already been driving 8 hours. And then more recently, in the last few years, with sort of the evidence that have come out with thrombolysis and ECR, that we can extend it out to 24 hours. We have worked with the paramedics New South Wales Ambulance to extend that bypass out to 24 hours. So instead of it being 4.5 hours now, we're at 24 hours. So anywhere within that 90-minute drive time. If it's more than that within rural New South Wales, where they've got protocols to help with retrieval to that New South Wales TeleStroke site.
Any advancements in ICH that we could talk about?
Yes, that's what I can.
Yeah, I mean, I know there's people in the audience who are very familiar with, you know, I call it the Rodney Dangerfield of stroke. Can't get no respect. The ICH, which is the minority. You know, it's about 15% of stroke overall in Australia, and has been the harder one to treat because we haven't been able to really identify strong acute therapies like lysis and endovascular clot retrieval. And with that, unfortunately, what comes is a sort of a lackadaisical attitude towards it. People just kind of shrug their shoulders, walk away. And it has also fallen between services. It's sort of, well, that's a surgical problem. And the surgeon said, well, it's not really, it's a stroke, it's a medical problem. It ends up in no man's land. And what has changed, and again, Australian led, Craig Anderson has been a big part of that, who many of you know speaks at these conferences often, has led a series of trials which have shown a modest but measurable benefit in outcomes if you lower blood pressure, but do it very, very quickly. And it makes sense, right? If you had a leaky garden hose, which is really what a hemorrhage is, you'd probably turn down the faucet before you tried to tape it up. And it seems to help clotting and improve outcomes. And that's really is what's spurring all of our efforts now to have our code ICH protocols, where we're actively looking at people, trying to manage them acutely, looking at their anticoagulants, reversing that when we can. I'll talk about something else when you ask me about AI later that's related to hemorrhage. And of course, our efforts to demonstrate that surgical resection of a hematoma continue. they started the history of this is interesting. The first trial goes back to before I was born, 1961, which is in the pre-CT era. People have been trying to show a benefit for surgery. And so far we have one positive trial in a limited subgroup of patients, but the techniques are evolving and they're getting better, more minimally invasive. And I think there will be a role at some point. We're entering a really exciting time in medicine, right? AI, it not only helps physicians like us, but it's also becoming increasingly important in surgical planning and even conduct of surgery. And combined with robotic surgery, I think you're going to see much more what might be considered technically impossible procedures now being done, and perhaps there's a role for that in the future. I might be a little bit optimistic, but I'm not an AI doomsdayer. I'm an AI optimist.
Michelle?
I was just going to do some interpretation for the audience.
Sorry. Yeah, you do that.
ICH is intercerebral hemorrhage. ECR is endovascular clot retrieval, which is the surgical removal of clot. And reperfusion is the reopening of the artery to enable the blood to flow through. And I know we do know that, but sometimes when it's thrown at us in those letters all the time, we get a bit confused about it, at least I do. But I think that that's an important thing that we need to keep in line, that when we are faced with these new technologies, understanding them is really important. And I think we're doing a great job within the ACI network to get these new pathways in place and having our members understand them, and it's part of the process.
Brenda, have you got anything you'd like to add to that part?
Yeah, actually, I'm going to plead stroke memory. Can you repeat the question again, please?
We're just talking about what you think the biggest gain has been over the last 25 years in stroke.
Okay, yep, I thought so. Look, for me, one of the biggest gains is the increasing involvement of consumers, people with lived experience in all aspects of, policy development, guideline development, standard development. I think that's made things more relevant for people who are, experiencing a stroke, that, that the voice of what's important is being heard. And that's really evident in the stroke guidelines. I was really lucky. So we're talking about an advancement. The intercerebral hemorrhage pathway that's being formed is a game changer for people who have intercerebral bleeds, because can you still hear me? Yeah, okay. Last year we got there was a meeting in Sydney, and there was a huge room full of clinicians that came together, and Ken was there, and Michelle was there, and it was the opportunity to get a national consensus on the way forward, and for that to happen, that's major in stroke, and so. And the other thing I actually wanted to, it's not major, but I think it's important, is the nurse-led, because being a nurse, the nurse-led intervention of management of temperature, blood sugar and fever, sugar and swallow, things like that make a difference for stroke survivors. And, so when a person's in a stroke unit now, they have this protocol of managing, these, the blood pressure, I'm tired, the temperature, blood sugar and swallow. And so it's making things, outcomes for stroke survivors better.
And so can I ask, Brenda, given that the huge involvement now we have with stroke survivors, what impact do you think that's had on the the clinicians?
It's been a big change for clinicians to, you know, sit down and have a conversation and understand the different perspectives. You know, a stroke survivor's perspective and a family member's perspective. They're all very different. So all the different voices that come to the table in providing, you know, the information about the changes that are required. You know, one thing we don't do well, and this is nationally, is we don't do discharge care planning very well. But it's a conversation that we all need to have together. And I know that the clinicians, all the clinicians, are really keen to get it right.
No, very much so. And so I guess my next question, we're talking about technology. So given we've got clinicians answering phones, Ken, would you like to start off and talk about TeleStroke and the development of TeleStroke and how technology has helped that?
Oh, okay. I'm always embarrassed when somebody says Ken's TeleStroke, because the truth is actually Bill started it before I was when I was back in Canada, and I was really right place, right time. There's a lot of other work that was done prior to me coming, and also I lead one part of the medical service, but it is a huge team that delivers TeleStroke. It is not one person's service. It is truly multidisciplinary, and it involves people right across the state. But I think I'm very proud of our service. I've been involved with TeleStroke. I was involved with TeleStroke, and did start a service back in Alberta in Canada in 2006. And it nothing compared to what we've been able to build here in New South Wales. The level of engagement and buy-in at all levels has been amazing. And I genuinely believe this. Well, I'll tell you, I'll put my money where my mouth is here because when I tell you at the end what we've done, I genuinely believe for most patients, for that first hour of stroke right now in regional New South Wales, if you are referred to our service, you are getting better care, or at least as good care as patients in the metro sites, because you are getting not a registrar, not a trainee. You're not getting a whole bunch of doctors by consensus and many phone calls. You are getting a neurologist and a stroke fellowship trained, a subspecialist neurologist. And that is an important difference. It's not a nuance. Looking at you in real time, talking to you, talking to your caregivers, your loved ones, and looking at your scans and examining you and making a decision just the same way that should happen in a metro site, you know, where you would expect the neurologist to be there and to come down and see you as I do in my hospital. And I say put my money where my mouth is. In my hospital, that doesn't happen consistently. It's a teaching center at the University of New South Wales. It's the major campus hospital. And after hours, the care is not done that way. It's done, you're not being seen by a stroke specialist because there's only one at my hospital and I can't be on 24/7. And a lot of your care is being directed by trainees, trainees making phone calls to other physicians. And there's a lot of decision by committee and a lot of deference. And that's not efficient, and it doesn't always lead to the right outcomes. And what we've decided to do at my hospital is we are in the process of initiating it as a TeleStroke site. So we are going to have the first metropolitan TeleStroke site in Australia, here in Sydney. And the idea is to provide that same level of care using the same group of physicians and the same pathways as we do in regional New South Wales.
Can I ask Ken, given these guys don't live and breathe stroke calls like we do,
Yeah.
can you maybe talk them through what it actually looks like?
Yeah. So if so, at a TeleStroke site, if you come to the hospital and are recognized to have stroke symptoms, and that generally means you're fast positive. I know that's an acronym. I apologized earlier for using all those acronyms.
Hopefully this
I
audience knows far.
everyone knows that because I know you're not medical, but I also know you're a more sophisticated audience because you're so familiar with stroke. But I think you're right. I make too many assumptions sometimes. So they're fast positive. So if you're fast positive and you show up, say, in Lismore, you will go through an online screening program that actually Bill developed that's available in all of the emergency departments. And we're essentially asking, what is your level of neurologic disability? We're asking the physician on the ground to do that. They don't need to be stroke experts to do that, but we do spend a lot of time training them in the protocol. When did your symptoms start and where did you come from? Did you come from home? Did you come from a nursing home? Are you independent? And at the end of that, they'll get an instruction. This is a candidate for reperfusion therapy or not. And if they are, call a 1-300 number. And they're not talking to anybody else. They're not talking to an operator in between us and them. They're not talking to a trainee. They're talking, if I'm on call, you're talking to me. Bill's on call, you're talking to Bill. We'll have a quick discussion. And if it's well, regardless, we're going to give some advice. But if it is a reperfusion candidate, we're going to take you and say, get to the CT scanner. We're going to go with you. And when I say go with you, it's a virtual go with you. We call you. And again, this is all we're doing when we're on call. So when we're on call, we are in front of our computer, 2 monitors, good audio setup. We're not running around a hospital with a mobile saying, do this and I'll be there. We are immediately phoning using, some of you may be familiar with Microsoft Teams. It's like a Zoom platform. That's what the hospitals use. And we're making a video call to a mobile workstation on wheels. So now the doctor and the patient and everyone there can see us on the screen. There's a camera on it and audio, so we can see the patient and everyone there and also hear them and talk to them. And we go to the CT scanner, we get all of the images and we're looking at them. And this is what I mean, like it's the technology that drives all this. We kind of take it for granted now, but it wasn't possible 10 years ago. But eHealth did a really good job of setting this up. So we're looking at the images almost as they're acquired. They're coming to our computer and we're assessing them and saying, this looks like a patient we can treat. We go back to the emergency department, talk to the patient, talk to caregivers that are there, examine the patient briefly and make a decision. And we actually are there for the treatment. We're there working with the nurses and the doctors on the ground. It's a team. And we don't leave that call until treatment is finished and everything is squared away. And our notes, which are done as a standardized note with standardized orders. So we're not all doing different things. We've all agreed on evidence-based, living guideline-based protocols that is put into the chart. And now that patient, their first hour of therapy is as good as you're going to get anywhere in the world. And if they need to, for instance, get out of Lismore because they have a big clot, a large vessel occlusion, we call it, but a big clot needing clot retrieval, we'll arrange that. We'll talk to the closest hospital. Since I'm in Lismore, that would actually be going out of state. It would be going to Gold Coast University Hospital and arrange for that patient to be accepted for transfer to that hospital. So that's what it looks like. Is that
Thank you, Ken.
what you were looking for?
Yep. So moving on to Bill, do you want to talk us through RISE and what that looks like?
Yeah, sure. So yeah, RISE is kind of our latest, evolution of data and benchmarking for stroke care in New South Wales. As mentioned, data has been there forever with audits, National Stroke Foundation audits, SITS databases, etc. And it's important to be able to say where your service is at. Where do you land in terms of these key performance indicators with access to stroke units and getting clot busting drugs and stuff like that. And, you know, over the years, we've worked towards getting that across the state. Limited success at times, and, you know, pockets of good success, and then, you know, failing it in other places. And RISE, we've got commitment now from all of the centres to put in the basics of what good stroke care looks like, so that we can report on it, look at it, and I think it reflects what we've learned over the years, that, you know, data in and of itself doesn't fix services. I think that, you know, good services have good data. It's at least as, you know, it's a two-way street. Those that don't put in that data, don't have that data available, it's a strong reflection of their service and not a good one. And we've also learned from you know, that experience, that more isn't necessarily better. So we're kind of sticking to a core set of KPIs. You know, good care, what does that look like? That will give us a broad understanding of how we're going, without going, you know, there's sort of limited, or there's diminishing returns as you go further with more data. You're not necessarily getting more value for it. So all the centers will be entering it in. It's live. The reports are there. I think that this allows us not only just to enter the data to benchmark against all of us across the state, but you get that feedback almost immediately, so that, you know, there's that's what builds the data. Is only one part of it. It's feeding back to the team. How are we going? Are we getting better? How do we look like against other services? Are we improving? So yeah, it's early. We've sort of just kicked it off. I think this iteration of RISE, which will be the statewide database since July. And yeah, I think the fact that people have committed to it will be a big step in the right direction, because I think what we've had is good sites, good services with good data, and now trying to get everybody on that journey is going to be important. Does that answer?
Can I just add one thing, or two things for that? RISE, by the way, is an acronym. It just means Realising Improvements in Stroke. And the second one is that every hospital can see their own and others' data, so you can benchmark. So Lismore can see everybody else's, and you can say, oh, I'm similar to RPA, but not performing as well as just Gosford. I'll reach out to Gosford so they can help me try and achieve this measure. So it's about kind of working together. So as a state, we're improving.
So onto the statewide aspect then, the 30, 60, 90 targets, can you talk about what those are?
Yes, so I mentioned them before. The 30, 60, 90 targets were set at a national level, and they're all about that reduction in meeting some of the standards. So the door to needle time less than 60 minutes, for patients who are sort of in a metropolitan centre to be able to retrieve them out for the clot removal surgery within 60 minutes. If you're a primary presenter, so your stroke, you turn up to one of the comprehensive centres. We have 6 comprehensive centres in New South Wales. Majority are in metropolitan Sydney, and we've got one in John Hunter. They're the bigger centres that provide that clot removal procedure. They also obviously manage neurosurgical interventions. But if you were to present to one of those hospitals, the target now is to reach the clot retrieval procedure by 90 minutes. So you would have had to have your thrombolysis, and then if you require it, clot retrieval. So leveraging off sort of the RISE database, we're able to now track this in New South Wales to make sure that we're meeting those targets. We've got a little while to go with some of them, but some of them we are meeting. And then the final one of those targets is sort of stroke unit access. So I think it's 100% of patients within New South Wales reaching a stroke unit, and that will align with the Commission standards and the National Stroke Foundation guidelines as well.
And can we give a bit of background as to why they were implemented in terms of the national numbers? Like the door to needle times nationally and things?
Bill?
Yeah, I mean, we were really falling behind internationally when we compared ourselves to the US, the UK. I mean, UK is, you know, is pedestrian in a lot of things, but at the basics of stroke care, they were getting it right. And the states in particular had put sort of what these targets should be maybe 15 years ago, and they went on that journey, and they went from improvement to improvement to now, you know, they were, you know, it was shameful, like some of our numbers when we compared it, we were behind by maybe 30, 40 minutes, median numbers for thrombolysis, which is, you know, twice as slow. That's, you know, it was not good. And by putting those numbers there for everybody to say, this is what we need to achieve, got it endorsed by all the different groups, it laid the sort of, these are the goals. And surprisingly, I think, because, you know, you think that by setting goals, you wouldn't achieve major change that quickly, but by putting it in and saying, this is what we need to achieve, there has been big improvements even in a short period of time. It focuses people, it gets them thinking about, it gets them looking over at the other fella and what they're achieving. I think that's, you know, the Angels Awards, which is another looking at some of these metrics of what good care looks like. It's brought in a you know, a healthy competitiveness and an awareness of what can be achieved. And, you know, people make excuses, or they don't necessarily focus on how they're going all of the time. It's how they're going some of the time. And so they have a bit of a sort of a rose tinted version of how they're going. This has really sort of shone a light on what we should be achieving. And there's sites in outside of New South Wales that are achieving, you know, door to needle times of 30 minutes. And when you hear that, you're immediately going, okay, well, that's the new bar.
And so on to technology further, artificial intelligence. Ken, where is that looking in stroke?
Yeah, you may have heard of artificial intelligence. It's it seems like it's everywhere, and it's when people ask me, "What are you doing these days?" It almost sounds trite to say, "Oh, I'm doing AI," because everyone's doing AI. So artificial intelligence and stroke. First of all, what I want to start with what it's not. It's not Chat GPT and large language models. It's not. Let's ask the computer if we should treat you or not, or what this is. It's much more basic than that. That's really leading edge artificial intelligence, but there's some less sexy stuff that those large language models were actually built on. Some older stuff, which, you know, up until a few years ago, really was limited in application to computer science labs, you know, electrical engineers, et cetera, doing this really complicated work. That those tools now are becoming available, and they do have a lot of applicability in stroke. And so I've been developing some of these, we call them models, basically to do things that humans would do. So that's the artificial. And then there's the natural, I guess. Natural intelligence would be people. And one of them is actually measuring on brain scans how big a stroke might be. And again, giving you an idea of how we operate as physicians. You know, we often think we're doing great. So this morning I got called by a very senior consultant who had a hemorrhage and told me the hemorrhage was 120 milliliters, which is massive. And I looked at it and I said, well, I don't think so. And the problem is she's estimating it, and she's using some tools that somebody's taught her somewhere. But unfortunately, once you get to a certain point in medicine, you're almost like a company of one. You're a CEO, you're everything. You're not getting feedback. You're not being told, actually, you're not doing that right, or you're not doing it as well as you think you are. And that's an example of where we can really get it wrong, myself included. And you don't find out unless you actually measure them. And there are techniques to do this. There are tools to do it, but they're really slow. They're basically, imagine drawing something on a computer with a mouse, drawing around. That's what you would do, but it's not practical. If somebody's having a stroke in front of you, you don't have time to do that. And the tools, even if you did, the tools aren't available. And that's a perfect place for artificial intelligence to actually say, not only identifying the stroke, because we can do that. The natural intelligence is okay. Bill and I can see the stroke, but to actually say, here's the stroke, and this is actually how big it is. And again, we're not deferring to the artificial intelligence. That's additional information that we're incorporating into our management plan. And we can say, sometimes we might say, that AI was way off, right? But it's additional information, and it has practical implication. In this case, this patient had a bleed, and we have criteria for using some of the new reversal agents, which are very expensive. And last night, when the clinician in question thought it was a much bigger bleed, she thought that that patient wasn't eligible for the reversal agent. But in fact, when I measured it this morning, it was 30 mils and the patient was eligible. So I think it is going to become these tools. That's just one example, and that's one I'm working on. I think I may have shown some of you at previous talks some of my early models. I think these are going to be increasingly used. That's just one example. It is the future. There's lots of it'll take some time to adopt. There are risks, and it has to be done carefully. But again, to me, as somebody who's interested in stroke and wants to see improvements, it's an exciting era. It's an exciting new tool.
So moving into the future then, if you all were given a wish list with unlimited money, unlimited resources, what would be the one thing you would want to see in stroke?
Unlimited and one thing. Like what you mean? Surely we can have everything with unlimited.
We don't have time.
Unlimited money. One thing. God, no, I'm not going with that. Look, I think we take the whole journey and we see all of where we've done really well. We've done really well pre-hospital. I think there's another version of that, as mentioned, where we uplift our ambulance guys to do even better, to connect with us. I think we've got our stroke units. I think that bringing that further, not just a geographic area, but really working as a team. And I think our outpatients, I think that, that and I see this through TeleStroke in particular, where I get to read the notes of other services and what they're doing in the community. And, there's really good things happening to support the follow-up of these patients and the recovery that, for instance, certainly on the coast with us, we don't have that access. So pre-hospital, more in that stroke unit piece. And yeah, that outpatients, there's a medical side to it, the secondary prevention, but also how to just coordinate the journey once they leave the hospital.
Brenda, what about you?
Okay. Look, when you said one thing, it's really hard to narrow it down. I'm just incredibly grateful for the one thing that is happening, pardon me, is that the involvement of stroke survivors and carers in shaping the way our care is planned and directed. We're also heavily involved in research, and so by having that significant lived experience involvement in research, that guides the living guidelines, that guides everything that's going to be around making our care better. Stroke units have been, I reckon personally, the biggest game changer that we've had. A stroke, when I had my stroke back in 2001, there weren't stroke units. So that to have all, what's happened in stroke in the last 25 years of stroke units, thrombolysis, clot retrieval, and all of those things. It's just been it's been an amazing 25 years to come from what we had in stroke back 25 years ago to now. There's still a lot more to do, but a lot has changed in those 25 years.
Nat or Ken?
Okay, I'll go off the back of the, just making sure that we're talking about before the stroke care coordinators and the nurse practitioners. I guess if we've got all the money in the world, then ensuring that we do have stroke care coordinators in every one of the sites, or nurse practitioners and CNCs in every one of these sites, just because they are leading the way in those services. I had one more, but I've just forgotten it. So you go, Ken, and I'm going to go. Oh, actually, I do. Can I go first? I think it's the making sure we've got the right number of beds as stroke units, but also that referral onto rehab. Like, if we've got all the money in the world, let's just offer it all, right? Yeah.
Ken, because Michelle's about to take the microphone.
I'll leave you. What? Sorry, what's that?
You go, because
I'll
Michelle's
go.
about to take over with a rehab rant.
Oh, are you? Oh, well, I was going to leave you with a little bit. I'm assuming unlimited resources means I can also solve, or I don't have limitations of current technology. How many Star Trek fans in here? I always say everything I needed to know about medicine and that I wanted to do in medicine, you can learn from Star Trek. What I want, I can see patients, I've been doing this for 30 years. I can tell when somebody's having a stroke, but I am reliant on so many other technologies which don't currently exist where you are, right? In that stretcher in the emergency department. I'm a 19th century physician without a CT scanner or an MRI scanner. I have no idea what's going on inside your brain without looking, or inside your skull without looking at it. And what I want is the technology that they had on Star Trek, right? They had the tricorder and they had the biobed, and it would just flip up on the screen and it would go, well, he's having a stroke and there's the artery. And no, they would tell you, oh, his DNA is dissolving too. And I don't need to see your DNA, but if I could see right where you are, this is exactly what the type of stroke is, I would save so much time, and it would be so much more efficient for everyone. And I think we'd be so much more effective. But the other thing that I need is to be able to treat you right there with near 100% efficacy. Right now, again, I'm relying on other people to do things that we're moving. We're going to a cath lab for, I'm sure in 100 years, they will look back at what we've done. It'll be like what we look back at what people did 100 years ago in medicine, right? It was like, what were these people thinking, right? It's barbaric. And again, watch the Star Trek episode where they go back in time and Bones says, dialysis, what is this? The Dark Ages? And hands some woman some pills and fixes her kidneys. And he actually treats a patient with almost a type of stroke. The guy has the subdural hemorrhage and he's arguing with the neurosurgeon about this. Neurosurgeon wants to open the skull and take out the blood. And he says, put away your butcher knives. Let me just fix the bleeding artery. And he pulls out his equipment and he fixes it. And that's what I need, right? I need the tools that I can say, that's the clot, and I'm going to remove it non-invasively, without cracking open your skull, without puncturing things. I'm going to remove it. I'm going to restore function. And I do think it's going to happen. It's probably, unfortunately, not going to be in my lifetime. But if you look at the acceleration curve in medicine, I don't think it's more than a couple of generations of physicians and surgeons away.
And being the good board member I am, Michelle, would you like to have the last word?
Yes, and I quite like the idea of you coming up with that in the next couple of years, if you don't mind, Ken. I'd really appreciate it. It'd be tremendous. And of course, I'm going to go with the whole issue of it's so important that everybody who goes into an acute stroke unit or is even treated for a stroke in any hospital in New South Wales has the opportunity for a full allied health assessment and therefore the opportunity to go to rehab. I think that's just one of the things that we're still not getting right with stroke in New South Wales. And I think it's it takes a lot of resources, and I'd love to see it happen. The other thing that I'd like to see, I'm with Bill, I'm having more than one. The other thing I'd like to see happen is I want follow-up clinics, the same one type of clinic that Kylie runs and Liz O'Brien runs, can be run by a nurse practitioner, but where people who have had a stroke can go back and be told what's going on in their lives by a clinician, because they often don't hear what's happening when they're in the stroke unit or even when they're in the rehab unit, and having the security of going back and speaking to somebody within that hospital system just to get themselves feeling that they're on the right track. And it doesn't have to be a whole lot of times, but just at least a couple of times. So they've got opportunity to say, I'm having issues with this. And you've got an expert who can say, oh, that's easy. Because a lot of the cases it is, sometimes it's not. But those are the two things that I want. Rehab is essential, and follow up with a outpatient clinic with a neuro, what are they called? What are you called? Secondary prevention with a nurse practitioner is just so essential for me. Thank you.
All right, well, I'm assuming we've gone over time now, and Lani's probably going to kick us off the stage, but I'd like to thank all the people on the panel today. It was a fabulous chat.